just in case there's some discussion at the end, I want to make sure we have time for that. So good morning, everybody. I am excited to present on this topic simply because it's something that I spend most of my day doing and thinking about, but also it's something that I find the changes that are happening in the field extremely interesting and exciting. And so hopefully I can spark some interest in some other individuals today as well in this particular topic. So I hope everybody's doing good with Epic so far. I'll start with that. And then we'll talk about so today we're going to talk about the current FDA-approved indications for deep brain stimulation and the areas that we target in the brain for that particular indication, as well as new indications that are currently being studied. And I think a lot of you are going to be really surprised at the list of indications that are actively being investigated. They're listed on clinicaltrials.org as studies that are currently enrolling and investigating deep brain stimulation targets. As well as some new innovations in technology in deep brain stimulation, including the use of MR tractography for deep brain stimulation and local field potentials and their role in DBS, particularly in their role in closed loop DBS, and other sensory modalities that may be, sensing modalities that may be used in the development and eventually, for coming to fruition, closed loop DBS in the future. So currently, deep brain stimulation is approved to treat essential tremor, Parkinson's disease, and dystonia in the movement disorder world. And then obsessive compulsive disorder is also an FDA-approved indication. That's a stimulation in the anterior limb of the internal capsule typically. And then epilepsy is also approved for deep brain stimulation, and that's typically with stimulation in the anterior nucleus of the thalamus. So the epilepsy is pretty new. Everything else has been pretty well established for quite some time, and there is some overlap occasionally with some of the areas of stimulation, but these are the most common areas of stimulation for these particular indications. These are indications that are currently being investigated for deep brain stimulation. So it's everything from pretty much anything you can think of in psychiatry to chorea and Alzheimer's disease. There's a lot of addiction type stuff on the list here that's currently being evaluated for deep brain stimulation, cluster headache, stroke, which we had a really lovely talk a few years ago about deep brain stimulation and stroke. So I think there's going to be, potentially a lot of change in the field, and also a lot of differences in the way that we think about deep brain stimulation. Because in stroke, for instance, when we were learning about that at Grand Rounds just a couple of years ago, that practice of deep brain stimulation is quite a bit different than the way that we use DBS now. So in the situation of stroke, where it's a monophasic event that's not degenerative, deep brain stimulation is used in combination with rehabilitation to help the patient basically speed their rehab or bring back more function than they would have with rehab alone. But then at this point, we don't really know the role of long-term DBS in those individuals who had a monophasic event. So there may be a lot of things here that folks are using deep brain stimulation for a finite period of time in combination with rehab versus chronic stimulation like we use in the current FDA-approved indications. Just last week, Dr. Robertson was asking me about a patient who had read something on the internet about cerebellar ataxia and deep brain stimulation, and while that seemed not right, I said, well, I don't know, because all of this is so rapidly changing, and let me go and look, and it wasn't ready for humans at this point based on the reading that the patient had done, but it was something that seemed plausible simply because of all the expansion that's being done in deep brain stimulation for multiple other conditions, neurologic and psychiatric. So how do we come up with all of these potential indications? So one way that can kind of come about, or a complement to developing new indications for deep brain stimulation, is particularly in MRI tractography. And we also had a really nice presentation from a gentleman at Wake Forest who I'll feature one of his papers that he was presenting on the topic a few years ago. He came and did a did a DBS grand rounds as well. And in his area of research, he's using MRI tractography to predict the effect of stimulation in a specific area. And I'll show you some pictures of that. But that's something that when we talk about what DBS is really doing, while we're stimulating a specific nucleus, the downstream effect, what's happening at the end of those cells that we're stimulating, is really what's of interest, and not necessarily focusing on the specific part of the brain that we're stimulating, but rather the effect. What are we inhibiting and what are we activating, and where does that go? So tractography is helping for us to understand potentially new targets for stimulation, and not only in what the downstream effect is, but also in identifying fiber bundles that we can't normally see on MRI with very much detail, particularly areas of the brain that are really white matter dense that we're interested in trying to stimulate. For instance, there's some really positive research in stimulation in the dentatorubro-thalamic tract for essential tremor. So sometimes we have trouble with individuals responding adequately to VIM stimulation, or maybe anatomically they're having a lot of difficulty with low thresholds for side effects within that nucleus for that individual. And so the DRT tract is being evaluated for potentially kind of additional target for essential tremor. That's something that really cannot easily be seen and not easily targeted, but with tractography, that's something that we're starting to learn a little bit more about as a potential target and being able to identify in an individual patient, not necessarily across the board, but for that individual, being able to find the DRT more accurately and being able to stimulate there. And also the ability to identify pockets of cells within a particular nucleus that we're interested in. So it's well accepted that in the subthalamic nucleus with stimulation, even though it's a very small target, there is a specific area that we're really wanting to stimulate that is most helpful for control of bradykinesia and rigidity, and that's the sensory motor part of the subthalamic nucleus. And so tractography can be used to identify that part of the nucleus with more relative accuracy. I don't know that that's something that's necessary because most people's subthalamic nuclei are pretty similar, but in looking at the connectivity between the primary motor cortex and the subthalamic nucleus, or the supplementary motor cortex and the subthalamic nucleus, and being able to identify for that particular patient and what we're wanting to accomplish for that particular patient really could add to the level of benefit that an individual would get out of deep brain stimulation. So this is an example of tractography and the research that's being done on the use of tractography for finding novel deep brain stimulation targets. So this is Dr. McIntyre from Wake Forest, and he's got a lot of interest in using tractography for this, particularly for psychiatric conditions. So this particular lead is placed in the subcallosal cingulate, and so this is something that's not, this is a novel target that's being investigated. And so in A, on this particular diagram, we're seeing just where the lead is placed, and this is a typical 4-contact lead. And contact 3 is highlighted here in red, to identify the target that actually turned out to have the most beneficial effect of stimulation. C, and I'm just going to make sure I say this correctly. So C is the white lines represent axon model trajectories passing by the DBS electrode. So everything that could potentially be activated by turning that electrode on, essentially. And then when we look at E, E is what happens, what theoretically would happen, those axons that would be activated by stimulation at contact 3. So this is considered the therapeutic pathway for stimulation based on this model. And then F is an example of stimulation at a different contact and the areas of the brain that would be activated by stimulation in a different contact, so a non-therapeutic contact. So even within a single electrode, you can see the big differences, truthfully, in the areas of the brain that are activated by stimulation within a single electrode by separation of fractions of a millimeter of space, really, and the differences of the downstream effect. So particularly talking about novel targets, very small targets, things that are that we're still learning about, this is something that can really help us to understand the ideal approach and how to best treat these individuals. And so in this particular model, they determined that the patient also had a good clinical effect from stimulation at contact 3. And so that was a correlation. This is a real life model of an individual and their particular tractography. So this would be something that would be applied to a specific person. It would be difficult to use normative data for this, but in terms of determining new targets as well as targeting for a particular individual, tractography seems to be likely to play a role in the future. Okay, so the next part we're going to talk about is another piece of technology that's not new, but that is kind of rapidly being incorporated into clinical deep brain stimulation. So I have been trying to spend time over the last year or two trying to learn more about local field potentials, simply because I know that this is probably going to be coming down the pike as something that is important in deep brain stimulation and the development of closed loop deep brain stimulation. And what I mean by closed loop is currently deep brain stimulation relies on a programmer like myself to determine areas that are therapeutic, areas that cause side effect, thresholds for stimulation, putting everything in, and it just runs continuously, no matter what the patient's doing or what's going on. And closed loop stimulation, that's called open loop stimulation. And closed loop stimulation is reactive stimulation, so kind of like a RNS for epilepsy, where it's sensing something and then reacting to it. Local field potentials are really a big area of interest as the thing in deep brain stimulation that the stimulator would be sensing and reacting to. And that actually is coming to fruition. Medtronic released a new IPG last year for deep brain stimulation that does have the sensing technology and is making recordings. So it's not stimulating based on the local field potentials that it's recording, but it allows us to see the local field potentials in the immediate area of that implant and making correlations if helpful to us. So right now it's kind of more just in the data gathering stage of out in the real world, when we put a deep brain stimulation electrode in, what are we getting and how does it react to what we're doing therapeutically in the clinical sense? And so local field potential, I think, is a lot of the future of closed loop deep brain stimulation. So I wanted to spend some time talking about it. And local field potentials basically are signs of what's going on in the synaptic space. So local field potentials record small populations of neurons and the extracellular potentials of what's going on in a small field of neurons. So it's not a single cell, it's a small vicinity of cells in it where the electrode is placed. And the main contributor of a local field potential seems to be synaptic current in neurons. It's recording other things too, but the synaptic current seems to be the biggest thing that contributes to a local field potential. And just like EEG or electrocartography, we're characterizing local field potentials by frequency bands. So there's alpha, beta, gamma, just like what we think about in EEG. And unlike EEG, local field potentials are a relatively localized population of neurons. And it's unique because there can be big differences in the signal of electrodes that are separated by really just 1 millimeter. So we're recording pockets of cells even within the same nucleus. EEG samples a large population of neurons because of all of the tissue that the signal must get filtered through before it gets to the scalp electrode, but local field potential isn't subject to that as much, and so we can get a better idea of a very small area in the brain and what it's doing. So in the basal ganglia, there's actually not a lot known about what normal local field potentials are in people, but in Parkinson's disease, one thing that's very clearly recognized is that the local field potential in people with Parkinson's disease is a little different, and there's prominent oscillations at a beta frequency in the subthalamic nucleus and GPI. So this diagram is just an example of what beta frequency looks like. And so in line A here, this is a local field potential in an individual with Parkinson's disease off of levodopa in the subthalamic nucleus. So this is a beta frequency, and then in C here, we're showing at the beta frequency, so between 10 and 20, basically here, we have this large spike of local field potential power within the beta band. And the big thing that makes this an interesting biomarker for Parkinson's disease is that this changes when the individual takes levodopa. So within the same recording area, we see that on levodopa, the frequency of the oscillation changes. So it goes into a gamma frequency of somewhere around 60 to 70. And the power of the band also goes down. So it sort of just kind of spreads out a little bit. It gets faster and it spreads out when people take levodopa. So this is some sign of probably, and we'll get into it more later, but definitely the correlation between how the person's doing motorically and what their local field potential looks like. There are other local field potentials that are associated with conditions in the basal ganglia, but they're less reliably recorded at this point in the literature. So in dystonia, for example, in the GPI, there's been evaluations of a lower frequency band of alpha in the 4 to 10 hertz range. But also in dystonia, there's a lot of literature that discusses also having a pathologic beta band. So differentiating dystonia from Parkinson's disease sometimes in the basal ganglia seems to be a little bit difficult. So I don't know what path that's going to take in the future, potentially for closed loop deep brain stimulation. And then there are also frequencies in the gamma range that are recorded that are considered to be prokinetic. So probably what's a little bit more normal to be in the subthalamic nucleus, for instance, is a frequency more in the gamma range, and it's associated with movement and arousal. So that's more of a good thing to see, probably. Low beta and theta frequency oscillations are also being investigated as biomarkers for essential tremor in the thalamus. And I'll talk a little bit about closed loop stimulation for essential tremor as well. So that probably will require kind of a combination of sensing in order to get adequate control of essential tremor with closed loop stimulation. So more about beta band in Parkinson's disease. As we talked about, it's widely agreed that excessive beta oscillations in the STN and GPI are seen in Parkinson's disease. In all people, there are beta oscillations in the basal ganglia, and all for Parkinson's disease as well as normal people, the beta oscillations are suppressed by voluntary movement. So again, it's kind of this resting state, and then the power of that beta oscillation becoming kind of too much pathologic in people with Parkinson's disease. With dopamine supplementation or deep brain stimulation, we can reliably reduce the power of beta band oscillations, and that clinically correlates with an improvement in bradykinesia and rigidity. Tremor predominant Parkinson's disease does seem to be a little bit different, and so that is also something that is kind of an area of question in terms of how would closed loop deep brain stimulation work in those individuals if we're really only looking at beta band power and suppression of beta band. In Parkinson's disease, the beta oscillation power directly correlates with the severity of their motor symptoms, and the power does seem to be really a major contributor to beta band power does seem to be synchrony. So what seems to be bad probably is that in this area that we're recording, the recordings that we're getting from multiple cells is a lot that they're all firing in synchrony, and that creates more of an issue with the beta frequency. So physiologic beta activity seems to occur in short bursts, but in Parkinson's disease, the duration of the bursts lengthen, which creates this increased power of the beta band, and that's a sign that the patient probably has bradykinesia and rigidity present during that recording. So I'll try to make that a little bit easier to understand because I probably didn't explain that very well. But these are pictures basically of an example of synchrony, like what contributes to power in a local field potential. So in green is a recording where there's low synchrony amongst the cells that are being recorded, and then in red is a high synchrony recording amongst the cells that are being recorded. And you can see here in this graph in B, this is a measurement of power of those local field potentials. And so power is low in recordings where there's not much synchrony between the cells that are being recorded, but when the cells are firing synchronously, the power goes up significantly. And so the synchronous firing of cells in the substantia nigra that are being recorded probably contribute to the pathology that we're seeing in the individual, or at least is a sign of pathology that we're seeing in the individual. I don't want to imply that there's some causative nature to what we're recording in local field potentials, but it correlates with the clinical symptoms that the patient's having. So the power, it does seem to be associated with synchrony, and so that's something that current studies in closed loop stimulation are really targeting. So I'll show you an example of that. So this was a really cool study, and I'm actually going to show you a video of this just because it has such good examples also of just typical Parkinson's and the effects of deep brain stimulation. So what these individuals were interested in is recording the power of beta band in response to deep brain stimulation at different intervals. So they've already worked with the patient and determined kind of ideal stimulation parameters for their subthalamic DBS, and then how does beta band respond at increments of 25% of that target stimulation, 50% target stimulation, 75%. So I'm going to show you a little video and I'll kind of narrate what's going on. So I've skipped ahead in the video just a little bit because there was some introduction, but what basically they did in the study was they put basically like an oscillometer on this person's hand, and their test of bradykinesia was them flapping their wrists back and forth. So here's a video of the patient that they're testing who has subthalamic DBS, and this is his ability to perform the task of moving his hand back and forth without stimulation on, and then with stimulation at 25%. And I just love this video because it's such a good example for, particularly for the residents to see like what that decrement in amplitude and movement really is. And so this is a video of him at 50%. This is at 75% of his target stimulation amplitude. So he's still having some decrement in amplitude, but then he is clinically doing great here. So they're demonstrating like, yes, clinically this stimulation is awesome for him, and so we want to see what his beta band is doing. And so that's going to be the next slide here. So the colors correlate on this graph as well, that this is an example of the beta band power within those red lines here at the frequency of about 20 hertz. And you can see that the power of the beta band goes down significantly when they turn the stimulation up. So correlating with his clinical symptoms. And then in this moving graph here at the bottom, they're showing that those long duration bursts are probably what's contributing the most to power. So the top recording is actually the local field potential, and then the bottom graph is the power of that local field potential. And so the longer the burst of beta frequency signal, the higher the power of that local field potential, and that likely is what's contributing mostly to the pathology. And why that's important is that, I'm sorry, I'll apologize, let me fix this real quick. That's important because that's what we have to figure out when we're actually trying to create closed loop stimulation. What are we going to target? Like, how do we design it so that it knows what to look for, basically? Because beta's okay, and beta's present, but then, like, how do we design something to look for pathologic beta? And that's what they're looking at now, is looking at these long bursts of beta as something that they can target that are contributing to these big spikes in power of the beta frequency. That's a sign that the patient's motorically not doing well. So I hope that makes sense. That's mostly what folks are interested in, trying to design a computer model on what to target. So in deep brain stimulation for Parkinson's disease, we do get information from the brain, obviously, when we're putting in a deep brain stimulation electrode through microelectrode recording. But microelectrode recording for DBS placement is really just looking at the depth of the electrode so that we can be in the appropriate target. So this diagram here is an example of the microelectrode recordings of different depths as we're going toward our target of the subthalamic nucleus. So the internal capsule, and an example of what the internal capsule microelectrode recordings look like, and then the zona incerta, both kind of being like low amplitude, slower microelectrode recordings. And then within the subthalamic nucleus recordings, they normally are firing at a little bit higher frequency than beta, but do still occur in these burst patterns. So it's kind of normal for there to be some bursts of electrical activity within the subthalamic nucleus with some pauses in between, but there are just nuances to that signal that seem to make things a sign of pathology in individuals with Parkinson's disease. And then for depth purposes, when we get into the substantia nigra, then we see that that has a higher frequency, just more continuous rate of firing. So there are definitely differences in background activity, so kind of what we're hearing in microelectrode recording, depending on the area that we're in. So that's the purpose of microelectrode recording currently when we place a deep brain stimulation electrode. Contributors to what we're hearing are just neural discharge patterns, and then to some degree also response to peripheral stimulation, so listening for when we move the patient's arm, are we hearing the localization of that in the electrode? Like, is there suppression of the electrode, what we're hearing on the electrode through movement? So we're actually interested in that as well, and also somatotopically organizing ourselves toward the body area that we're interested in by doing those movements. So with microelectrode recording and placement of leads at this point, all along, we've really just been interested in trying to place the electrode in the sensory motor area, but not necessarily worrying about or thinking about what the characteristics are of potentially some of the electrical signal that we're getting. So is it different in certain areas of the subthalamic nucleus compared to others? So it's just identifying that's the subthalamic nucleus, and then somatotopically, yes, we're in an area close to the arm that we're really interested in, and that's it. And that works well because it helps us to get into the sensory motor area. But evolving technology really may change some of the ways that we think about placement of the electrode. So in the future, there may need to be consideration of trying to find beta islands in order to secure a good clinical outcome for bradykinesia and rigidity, because as we talked about with local field potentials, there can be differences in the recordings that are very significant even over a very small area of recording. So separating the leads by a very small distance can lead to fairly significant differences in the recordings that we're hearing. What the reality is, probably if this was going to be something that comes to market in the future, is maybe not necessarily changing the way that we're placing the electrodes, but potentially placing more electrodes in a smaller area to increase our likelihood of recording and capturing beta band. That's kind of what's been happening in animal models, for example, in kind of application of this type of technology. With the Medtronic technology that's been brought to market, they have published some data about our ability to record beta band with traditionally placed subthalamic nucleus electrodes. So they published some information on 7 centers using the Medtronic leads placed using traditional methods, so using normal microelectrode recording methods. And in those electrodes, they were able to record sufficient beta band in 79% of patients with akinetic rigid phenotype of Parkinson's disease and 92% in tremor predominant phenotypes. And they definitely noticed some differences in the beta that they were recording, with the akinetic rigid phenotype being broader beta and more powerful beta peaks, and then in people with tremor having a little bit of a different character to their beta band. And there was a correlation, so with the programmer being blinded to what the beta recorded beta was looking like in just doing a traditional method of programming that individual, there was a clear correlation between what the clinician chose to do with programming and how that affected beta band in a predictable way. So looking at the patient, deciding what to do clinically, and then going back and looking at beta was higher in the recordings of the contacts that the clinician chose to use. So there was definitely a correlation between this works best for their Parkinsonism, and this is where beta is the strongest. So that actually did make sense. But as you can see here, with 79% of people using traditional lead placement techniques, that was all that was found. And so while that's a good number, that's a big number, that wouldn't be sufficient for everybody to be able to have closed loop DBS, obviously. So there's going to have to be some change in the way that we clinically do this, but it does seem like there could be a good future here. Okay, and then talking about essential tremor just very briefly, because I think a lot of us that work in DBS probably feel like the future is eventually going to go to closed loop systems for most conditions. And essential tremor is the most common movement disorder in adults, and so getting to the point of being able to treat those individuals also with closed loop stimulation is important. And what mostly comes up in the literature at this point is two local field potentials with possible triggers for closed loop DBS, which is a low beta frequency in the thalamus that is associated with detecting a voluntary movement. So with essential tremor, those individuals have tremor when they are using their arm. And so they're using a local field potential that detects that voluntary movement. So I'm not resting when I detect low beta, I'm getting ready to move, basically. And then a theta frequency local field potential that is indicative of postural tremor. So that's the two things that people are looking for in possible triggers for closed loop DBS. And in all closed loop DBS, but particularly in essential tremor, there are some factors clinically that are really important to being able to get to the point of closed loop or reactive stimulation. And in people with essential tremor in particular, there has been some signs that the brain habituates to the stimulation. So there's constantly this need to make some adjustments, particularly if the patient doesn't get any breaks from stimulation over a prolonged period of time. So most people with DBS for essential tremor, we recommend that they turn their stimulator off at night to give their brain a break, save their battery, potentially reduce the risk of habituation. And that's pretty well supported in the literature that probably does help. So closed loop deep brain stimulation with just responding to movement and tremor would also significantly help with that. And not all of our patients are very reliable about doing that. So this would definitely help with that situation. And then a lot of folks with DBS also suffer with stimulation-related side effects. Directional lead technology has certainly helped with that, but people with thalamic stimulation can very frequently suffer with dysarthria and tingling and sensory side effects related to stimulation. And there is a small population of individuals with ET and DBS that have settings that are my fine motor settings. So like if I'm eating or if I'm trying to write, I set my DBS to this so that I get great tremor control, but that comes at the cost of dysarthria, for instance, and so they're not going to stay there all the time. They're only going to use their stimulation at that level for that specific task, and then they're going to back it down or change to a different setting for their normal everyday activity. And that's really not ideal. I mean, that's like something that is a bad situation for everybody involved, frankly. I mean, it happens, but we don't want to do that. And closed loop stimulation that's reactive to what the patient's doing would really take the place of that, which would be great. So in ET in particular, closed loop stimulation would probably make a big difference for the clinical outcome of an individual with ET. With closed loop stimulation in the real world, so in individuals with ET who have typically placed thalamic leads, there was a study that looked at how closed loop stimulation affected the time that you were using the stimulator, and the energy that was used from the patient's battery was reduced to 36% of what is typically consumed with continuous stimulation. So 36% of what would be normal for the typical open loop stimulation. So it's a pretty significant reduction. I think, most people who are turning their stimulator off at night reliably also get a pretty significant reduction in their energy use of their IPG, but this was definitely above and beyond that, so that was great. And how reactive was it? Like, how accurate was it? Well, so stimulation was on 80% of the time when either that low beta or theta frequency was detected. So it reacted 80% of the time appropriately to when the person was moving and having tremor, and then the stimulation was only on 13% of the time when it was perceived that the patient actually didn't need it. So that's great. I think that's a good result. And then other ideas behind closed loop stimulation, let's say we're not thinking about using local field potentials, but what are other things that can be recorded that would help to contribute to closing that loop and being reactive to a person's symptoms? There are lots of things that are being evaluated, and kind of the old version of that was using external sensors like accelerometers or gyroscopes or EMGs of the forearm, for instance. But that's obviously less than ideal. I think that is open to a lot of interference and errors in the data that's being collected. So certainly the long road of closed loop stimulation would not involve any external data collection from outside of the brain. Electrocartography of the primary sensory motor cortex has also been studied in closed loop deep brain stimulation for movement disorders. That does also seem to work pretty well, but ideally we would be able to record from the single electrode that we're placing into the target. So the single stimulation electrode that we're placing into the target would be ideal. I believe the electrocartography is pretty similar to what's used, or that's what's used in RNS for surface sensing, and so that technology exists and that's being used. But for movement disorders in particular, the ideal situation would be to record and react from the same area. And then an area that's really interesting and exciting that actually is being investigated with technology that exists is neurochemical dynamics. So measurements at the neurotransmitter level and manipulating the neurotransmitter levels with deep brain stimulation. So I'm going to briefly talk about that. So there was a really cool paper that's now kind of aging, and so I'm not sure exactly where this technology is, but back in 2014 in Frontiers of Neuroscience about deep brain stimulation in the subthalamic nucleus and how that affects dopamine and being able to record and react to that. So this is an example of what the technology was at the time. And on the picture here, on the blue part of the electrode is recording of dopamine levels in the medial forebrain bundle of the rat model. So these blue areas are picking up on dopamine levels, and then this is a typical four-contact electrode for stimulation in the subthalamic nucleus, is basically kind of what this diagram is supposed to represent. And so based on the hypothesis that we think the subthalamic nucleus stimulation does increase dopamine levels, increase striatal dopamine release, the neurotransmitter, we can react to neurotransmitter levels and stimulate to basically bring neurotransmitter levels up to a desirable amount, essentially. And this actually does seem to kind of work. So the major issue here is that with these papers, and then that may be why there's no further publications at this point, but with this, there was no clinical correlate. So there was no information on like if the mouse could walk or anything like that, for instance. So we don't know actually what amount of dopamine we're really shooting for, like how much do we need to stimulate in order to get dopamine levels to a therapeutic amount? Is this something that's feasible in terms of being able to make a clear correlation between like if I can keep the brain dopamine level in the medial forebrain bundle the same all the time, does that mean that clinically I'm the same all the time? And we don't really have a good idea about that based on this particular type of sensing and stimulating technology. But this technology exists where like in sub-second time frames we can sense and stimulate in a reaction to neurotransmitter levels. And I think that's crazy cool. See, this is an example of actually what they were doing based on different stimulation parameters with the DBS. So the graph on A is oxidation of dopamine. So in the recording electrode how much dopamine they were seeing basically at the recording electrode, and with increased amplitude of stimulation, so they're giving more current in the subthalamic nucleus, led to peaks of dopamine at the recording electrode. And then this is also looking at the effect of pulse width on dopamine release, and also with higher pulse widths at the subthalamic nucleus, higher pulse width level stimulation at the subthalamic nucleus, they were able to see increases in dopamine at the medial forebrain bundle area of recording. Frequency was interesting, actually. There was a peak of dopamine at 100 hertz of frequency stimulation, but then if you pushed it higher up to 200 hertz, there was actually the amount of dopamine that was detected in the medial forebrain went down. So again, lots to interpret here, but it does seem at least that the technology itself works. And so it's a very cool idea, I think, and I would be interested, maybe not necessarily in Parkinson's disease, because again, just looking at dopamine, I think that's the area that we understand the best, but maybe in one of the psychiatric applications of deep brain stimulation could have a future in this sort of thing as well. So I think that's a very exciting path to the future also, but truthfully, very likely, I think local field potentials and being reactive to local field potentials is the future of closed loop deep brain stimulation. So in conclusion, there are as a huge expansion of the potential therapeutic indications of deep brain stimulation occurring. Everybody's interested in a surgical management option for different previously not treatable or situations where medically refractory conditions in neurology and psychiatry had not had other options. And so definitely folks are looking at surgical management options for those individuals, which is interesting and great. I think we have lots to learn about what contributes to success in stimulation for certain individuals and certain comorbid conditions. But I think it's a wonderful expansion of an area that I really enjoy. And then we talked about tractography and how tractography contributes to identification of novel targets and the effect of stimulation in a given individual, and being able to tailor stimulation to a specific person using tractography. And then using local field potentials for clinical practice, hopefully in the future, particularly in Parkinson's disease, and then maybe a science fiction version of sensors, including neurotransmitting sensors and reactivity to contribute to closing the loop of deep brain stimulation as well. So that's all that I had, and I'd be happy to discuss or take some questions if anybody has anything.
Dr. Holliday, this is Carrie Rimmel.
Yes.
Thank you very much. What a wonderful, exciting review. And I can think of a patient that we share that I sent to you
Yeah.
that I'll be calling you about.
Okay.
But yeah, this is wonderful. Thank you very much. I know that we are going to expand the field enormously, and you and Dr. Niemat will be doing research and taking this to another level. Thank you so much.
Well, thank you. Yeah, and I think in stroke, it's really, like I was saying, I think it's very interesting, and that's what actually Dr. Robertson had a question about in terms of the cerebellar ataxia and kind of how deep brain stimulation might be used in those individuals differently, because it's not really looking at chronic long-term stimulation, like how is this affecting brain healing? What is this doing, at a cellular level that I think we really don't understand very well at this point. So the potential application is huge, and definitely in a way that I can't even explain, because I love doing this talk because it helped me to learn a lot, and so I think it's going to be very exciting. I think it's very interesting. anybody who wants to learn how to turn a stimulator on, I'm happy to teach them. So,
That's great. Thank you so
thanks,
much.
Dr. Remmel. Thanks.
Victoria, hey, this is Joseph. I think that's a phenomenal talk. Thank you for such just a concise and complete summary of the field. It really was outstanding.
Thank you so much.
Yeah, I share your enthusiasm for closed loop stimulation. I think, as you said, it's going to be especially useful in novel indications. I think we sort of got lucky with the STN and thalamus being sort of the first major indications because it just seems to work there
Right.
pretty easily. When you get to things like our trials for depression and other indications, it's exceptionally difficult to get just that right spot. And I think that sort of a closed loop signal is going to be what people need to get it right. So I agree, obviously, that it's a very exciting field. Thank you for that summary.
Joseph, what do you think about kind of, let's just talk about beta band and, STN stimulation and in terms of like finding the sweet spot? Like, what do you think the technology is going to look for? Like, what is it going to look like? Do you think it's going to be just more than one electrode and then recording from more than one electrode, or what do you think that looks like in the future?
Yeah, that's a good question. It's interesting because actually Benabid, 15 years ago, made often when we are putting the microelectrodes in, we have what's called a Ben gun. It's an array of 5 electrodes that's adjacent to each other. And he made the suggestion with the current technology that, hey, we should just put in 5 final DBS electrodes, lock them all into place, and then of course leave the poor neurologist to sort out which of the 20 electrodes you're going to use. I think that I suspect it'll be something a little bit more refined than that, given the technology that we have. So I think having directional electrodes that you can read and direct toward the beta signal that you're seeing, and even technologies to improve what we see intraoperatively. Something that a lot of centers, including us, are doing now is, for research purposes, we're putting cortical electrodes out on the surface of the brain, and seeing how that correlates with activity in the SDN. There have been sort of further studies similar to what you showed, but showing that there's coupling between cortex and your deep target, and that may be also a very important indication. I suspect that future systems will utilize those with a permanent implant, that you'll have a grid on the surface and something deep, and that will be how you sort of organize your stimulation.
Yeah. Well, that's great to hear. Yeah, I like the idea of kind of changing also intraoperatively what we do, and I think that'll be a really nice part of the future. I'm excited.
Yeah, I think so. That's great. Thank you very much. Thanks for letting me sit in. I appreciate all the neurologists letting me crash your party.
All right. Well, thank you, everybody, and I hope everybody has a great day, and good luck with Epic today, and we'll see each other again soon.
Thank you.